Hi, everybody. I am Ann Moore. I'm a nurse practitioner with Arizona Liver Health in Phoenix, Arizona. We're a private practice clinical research and standard of care hepatology program. I've been doing this a long time. It's a pleasure to be able to talk to you today about pharmacotherapy for MASH and MASLD. And I'm going to tackle a few questions here. Question number one, what are the primary targets or histological endpoints for pharmacotherapies currently approved or in late stage development for MASH? So we're talking about clinical trial endpoints here. So we're really looking at two major histological endpoints that matter the most, both to regulators and to patient outcomes. So the FDA is in tune with these, and they really speak to patient outcomes as well. The first endpoint is resolution of MASH, which means reducing steatosis, inflammation, and cellular ballooning or cell death in the liver without worsening of fibrosis. And the second endpoint is the flip side of that. So improving liver fibrosis by at least one stage, again, without worsening the underlying MASH. So in some trials, you need to hit both of those endpoints. In other trials, one or the other. But those are the two target endpoints. And why these two? Because fibrosis stage is the strongest predictor of long-term outcomes like cirrhosis, liver-related mortality, and even overall mortality in these patients. So we're trying to stop inflammation in its track. And sometimes, depending on the mechanism of action of the drug, we're trying to actively reverse scarring. But the end result of reducing steatosis and inflammation is hopefully to eventually reverse that fibrosis, right? So these are the endpoints that define meaningful clinical success. They are tough endpoints to meet in a 52-week clinical trial, which is sometimes the point that we're looking at improved histology. So it's no wonder that 82 or more plus drugs are in the graveyard for MASH, but we finally have two that are approved, and that's pretty exciting times for us in MASH. So now we're going to move on to the first FDA-approved drug for MASH. And we all know what that is, Resmetirom, or Resmetirom is the brand name. March of 2024, the first FDA-approved treatment specifically for MASH with fibrosis, F2, F3 fibrosis. So what is Resmetirom? What is Resmetirom? The mechanism of action? It is a selective thyroid hormone receptor beta agonist, THR-beta. That's a mouthful. So from now on, we'll call it a THR-beta agonist. So I don't have to say that again, right? That sounds complicated. Even the name sounds complicated, right? But here's what it does. I'm just going to break it down in the and more simple. It has to be simple for my brain to understand it. It targets the liver to boost fat metabolism and reduce the toxic fat buildup that really triggers that inflammatory cascade and leads to fibrosis. So it interrupts that whole process by basically defatting the liver. It's a pretty fascinating target. It has only impact in the liver. It's very liver directed, no systemic thyroid impact at all. In the Maestro-NASH phase 3 trial, actually Resmetirom met both clinical endpoints that we were just talking about. About 26% of patients achieved MASH resolution with no worsening of fibrosis compared to just 10% of the placebo arm. And then the flip side, remember that, is it also improved fibrosis by at least one stage in 24% of the patients. Again, significantly better than placebo. And remember, that was in 52 weeks to reduce fibrosis by at least one stage. That's pretty amazing, if you ask me. So fast action on the fibrosis reversal. In terms of safety, it is generally very well tolerated. Most common side effects are GI issues like diarrhea and nausea. Typically, we see that onset in the first 4 weeks of treatment, and the symptoms, the side effects kind of go as fast as they come. So, most resolve in less than 1 month, and patients describe them as mild to moderate, easily controlled with over-the-counter remedies if they need something for diarrhea or nausea. Also, some patients have transient increase in their liver enzymes at about week 4 on treatment, no more than 1.5 times their baseline. And they actually resolve very gradually after that and hopefully improve even below their baseline on entry into treatment. There weren't any serious thyroid events or cardiac adverse events in the trial that were reported. I think overall Resmetirom represents a big step forward. Our first drug, on the market to treat MASH patients with F2, F3 fibrosis who just needed more than lifestyle changes. So it's a welcome therapeutic option for our MASH patients. So we'll move on now to what patient profiles are most appropriate candidates for MASH pharmacotherapy. I mean, we need to understand this to decide who we're going to treat, right? So right now, the best candidates for those with biopsy confirmed or NIT confirmed probable MASH and fibrosis F2 or F3, those are the best candidates. These are the patients that are most likely to benefit from pharmacological intervention. So when we look for patients with high risk metabolic features, we're looking for type 2 diabetes, obesity, any of the other metabolic syndrome, cardiometabolic risk factors. If they have more than one cardiometabolic risk factor, more likely they are to have MASH. So that's our target audience right there, to find those F2, F3 patients. And so we're really looking for not the patients on the early end, F0, F1, and not the patients on the cirrhotic or decompensated end yet, but the sweet spot is those F2, F3 patients. And more to come, later on when the cirrhotic data starts coming out. But for now, F2, F3 is the sweet spot where we can do the most good for our patients in specialty care. The F0s to F1s can stay in primary care, be monitored, because we're talking millions of patients here, and we don't have millions of hepatologists. So it's important, that we target our population in order to get the most care to the most patients that we can. So key is to identify patients who are at real risk of progression, but still early enough in their disease course to benefit from treatment, right? So question number 4 is, how should APPs monitor patients on MASH pharmacotherapy? So that's a tough one. I mean, because we're learning, right? We're pretty new into this, just about 18 months since our first drug and about, 3 weeks since our second approved pharmacotherapy. So monitoring is a major part. It has to be. Like, we're starting therapy, we need to know how they're responding. And number one, we can't biopsy to find that out. We don't have a perfect way to monitor yet, but we're learning so much about non-invasive testing. And this is where APPs can really lead, because we're prescribing the drug. We're going to monitor the patients. To track efficacy, we're going to look at repeating non-invasive tests like FibroScan, VCTE, ELF. If you don't have access to VCTE, it can just be done with an ELF. I feel like FIB4 is more for screening. It's not for monitoring response. And so while FIB4 is an excellent screening tool for MASH, I think we need to stick to other non-invasive imaging. If you have VCTE, if you have ultrasound elastography, if you're really lucky and have access to MR elastography, all of those are great options. If you don't have access to any of those non-invasive imaging options, then ELF is a commercially available laboratory test that you can use, enhanced liver fibrosis tests, and monitoring that every 6 to 12 months. And what we found in our office, we're treating many patients for MASH, is that if we document well in our notes why we're doing it, what we're looking for, the testing is typically approved by insurance. So you can also look, if you have zero access to non-invasive tests, you can do easy things like look at the ALT. If you're down 17 points on the ALT from where you started, that's indicative of a good response. That's data-driven evidence right there. You can also look at their metabolic risk factors. Are they getting better? Is their A1C better? Is their lipid panel improving? That can also give us insight into the metabolic improvement that we're looking for. I would not recommend liver biopsy, except in select cases if someone is not doing what you think they should be doing. And we try to minimize anything invasive unless it will change the management that you're doing. So typically, this is all looked at from a non-invasive standpoint. For safety, I mean, obviously you're going to monitor for safety. I just told you that at week 4, if you happen to get labs, you're likely to see a little bump in the AST, ALT that then resolves over time, but it's not going to be, a big increase. 1.5 times baseline was typical in the clinical trial. I'm of the mind that when I start a new medication, I like to look at 4 weeks, but I also like to know ahead of time what I'm going to find. And so we do a lot of 4-week labs after starting Resmetirom, or we have done over the past 18 months. And we do see that little bump on many patients, nothing to worry about. But then I typically continue monitoring liver chemistries every 3 to 6 months, along with thyroid function once a year. Now, this drug does not target systemic thyroid function, but just because we don't know a lot about this category of medications, to me, it gives kind of a peace of mind, just because perhaps resmetirom could have some downstream impact. And we did see decrease in T3 in the clinical trial, but it had no clinically significant impact on thyroid function overall. So you might see that if you're repeating the thyroid panel once a year. I mean, in MASLD patients where we worry about cardiovascular comorbidities, so we keep an eye on their cardiac health, lipid panels, things like that. If they have a cardiologist, we're making sure that they're following up. Bottom line, we want to really reinforce that medication is part of a comprehensive care plan. And you can't forget nutrition, activity, weight management, really control of those comorbid conditions, because the FDA indication was for resmetirom in conjunction with lifestyle modifications, including weight loss and activities. So this is important and a big piece of monitoring patients on MASH treatment. And that's it. Thank you.